All right. Good afternoon and welcome from a rainy Port of Spain in Trinidad and Tobago. I am Dr. Gregory Gerard Boyce. First time I hear my middle name, don't spoil it. Welcoming you to MRFTT STI Echo. This is our 34th session, and we are just going to identify to my left is Dr. Jeffrey Edwards, who's our director and multiple expert, and to my right is Dr. David Musa, who is one of our physicians who is as well clinical psychologist trained. We are going to dive into this session, which is a great treat for us. Dr. Edwards is going to give us a session on the diagnosis and management of vaginal discharge. And this is in concert with our recent women's health clinic, in which we see all of these sorts of issues popping up. So without further ado, I'm just going to invite Dr. Edwards to start his presentation. Let me just pull that up for him.
Okay, good afternoon, everybody. So we're going to talk about vaginal discharge today. Vaginal discharge in women, quite common. I'll talk about the differential diagnoses and how we manage men, and I'll talk about the common ones. Okay, next one. So I'll start off probably with a case.
We're not seeing the slides just yet, correct?
Oh, not yet. Okay.
Okay, it's coming up now.
All right, seen it? Good. All right, so as I said, I'll probably start with a case. In terms of the objectives, so I think it's one before, Is it? It's not all right, okay. We'll go through history taken in a patient with a vaginal discharge. I'll talk about the differential diagnosis of patients with a vaginal discharge, and then we'll be able to recognize the different presentations of vaginal discharge, and then initiating the appropriate investigations and treatment. Next one. So let's talk about a case. So a 25-year-old woman attends your clinic complaining of a 4-week history of a smelly vaginal discharge, worse after intercourse. She had already tried medication. She went to the pharmacy and got some clotrimazole or Candid pessaries, but this hasn't helped the condition. Next one. So the differential diagnosis of a vaginal discharge, go ahead. It includes a normal discharge. Some women just have a normal discharge, 30%. Next one. Bacterial vaginosis, which I'll tell you about, 23 to 50%. Candida, vulvar vaginitis, 20 to 50%. That's the typical yeast infection women get. Go ahead. Trichomonas vaginalis, sexually transmitted, 5 to 15%. Go ahead. Then sometimes there's a mixed infection or sexually transmitted infection, chlamydia or gonorrhea. Go ahead.
Oh, sorry.
That's okay. That's the next slide. Yeah. All right, other uncommon causes of the vaginal discharge, atrophic vaginitis. This is in older women. If there's a foreign body, sometimes I've seen women with a discharge, and then when you pass a speculum, there's a condom stuck up there that they didn't realize was up there. So a foreign body. It could be infectious, and infectious organisms are gonorrhea, chlamydia, very rarely herpes, all right? Or the patient may have a vaginitis or vulvitis, all right? They may have vaginal or vulval trauma. They may have irritant contact dermatitis, because people use all these fragrances and stuff, and they may actually react to the fragrances. They may have a vulvar vestibulitis, or there may be some malignancy. Sometimes cervical cancer could present as a discharge. Or they might have a cervical polyp or cervical malignancy. Next one. So that's the uncommon causes. Next one. Go ahead. Talk a little bit about the pathophysiology. So the normal vaginal flora of women contains lactobacilli. So disturbance of the normal vaginal pH and estrogen levels can alter the vaginal flora, which can lead to overgrowth of some pathogens. Next one. Go ahead. So factors that alter the vaginal environment include feminine hygiene products, all those hygiene products people use, you know, contraceptives, vaginal medications, antibiotics. Women know if you take, you know, antibiotics, you get a yeast infection. Of course, sexually transmitted diseases. Sometimes after sexual intercourse, women get a worsening vaginal discharge and stress and other mental health issues. Go ahead. So you approach the patient. So you need to take a history, all right? Ask about the discharge, you know, how long the discharge has been there, if it's itchy, is it burning, is it smelly, you know? So there are a number of things, I'll talk about it. Then you do examination, all right? What you do, you pass a speculum, that's a little instrument we usually use, and you look in, and you can also get a look at the cervix, and there are certain investigations we want you to do. Go ahead. So in terms of the history, you take a general sexual health history, ask them about the partners, number of partners they had, if they use condoms, you know, if you're on any form of contraception. And remember, they can use the oral contraceptive pill, or they might use the intrauterine contraceptive device, all these things. All right, then you'll take a gynae history, ask them of their last menstrual period, if there's any intermenstrual bleeding between the periods, post-coital bleeding after intercourse, or dyspareunia, painful intercourse. Then you ask specific questions about the discharge, the type of discharge, how long is there, how does it smell, is it itchy, is it painful, do you get burning when you pass urine, are there any genital ulcers? Ask them about their douching practices, because women still douche nowadays. Of course, ask them about antibiotic use, because I remember I told you that a recent history of antibiotics may be associated with a yeast or Candida infection. Take the general medical history of diabetes, you know, anything that might immunosuppress them, you know. And then ask for other systemic symptoms like low abdominal pain, fever, chills, nausea, vomiting, or as this might indicate pelvic inflammatory disease. Next one. Examination. Well, you need to exclude other causes of a vaginal discharge, especially since this lady actually used the clotrimazole pessary, all right? So what you need to do is look at the external genitalia, looking for fissures, vulvitis, sores, look in the groin for lymphadenopathy, that's swollen glands. Then you pass the speculum. Speculum, that's an instrument you put in the vagina. You can get a look at the cervix, see if there's any inflammation from the cervix. And of course, you can get a look at the discharge, look at the nature and the location of the discharge. When you're passing the speculum, it's important to use water as a lubricant, because if you actually want to take a swab and you use some of those gels, it may interfere with the swab results. So use water as a lubricant. After you remove the speculum, then you use a bimanual, then you do a bimanual examination. This is where the doctor uses his 2 fingers and pushes against the abdomen, and we try to rule out pelvic inflammatory disease. Pelvic inflammatory disease, patients may have cervical excitation pain, meaning tenderness of the cervix when you touch it, or they maybe have adnexal pain, that's an ovaries pain there. Okay, next one. So investigation, well, a normal vaginal pH is normally 3.5 to 4.5. So there are some little strips you can actually use to get a vaginal pH, all right? 2 conditions, bacterial vaginosis and Trichomonas vaginalis, raises the pH, all right, to 5.7. So if the pH is greater than 4.5, you think of bacterial vaginosis or Trichomonas vaginalis. You can do a pregnancy test, of course. You can do a high vaginal swab, or you can do endocervical swab. A high vaginal swab, you can do that to collect the swab for gonorrhea, chlamydia, all right? If you're doing a pap smear, you can also do a swab for a wet prep. The wet prep could help you identify bacterial vaginosis or trichomonas. Again, the endocervical swab, that's from the cervix. That's when you push the speculum. Again, you can do chlamydia and gonorrhea. And of course, if you're there and there's no discharge, then you could probably do a pap smear. Go ahead. So continuing the case, the woman is heterosexual and has been married for the past 3 years. She has had no other partners during this time, and her last sexual intercourse was a week ago. She uses oral contraceptive pill for contraception and has had no missed pills, so hopefully she won't be pregnant. And her last menstrual period was 3 weeks ago. Her pap smears were up to date and normal. On speculum examination, you saw a gray discharge adherent to the vaginal walls, and the cervix looks normal. Next one. All right, so you can see this grayish discharge there coming out from the vagina. Go ahead again. Go ahead. All right, go ahead. All right, so you see this homogeneous discharge adherent to the vaginal wall. Go ahead. And then when you pass the speculum, that's what you see. All right, you see the discharge in the cervix. Next one. All right, so because there's a smelly grayish discharge, you think in bacterial vaginosis. There are a number of criteria to diagnose bacterial vaginosis. There's something called the Amsel criteria, and 3 out of them are diagnostic. So if you see a thin gray-white homogeneous discharge which clings to the vaginal wall, as 1, clue cells. Clue cells are vaginal epithelial cells that has numerous coccobacilli in them. It gives it a kind of granular appearance. If the pH, remember the normal pH is 3.5 to 4.5. So if the pH is greater than 4.5, you think bacterial vaginosis. And then what you can do also, you could collect some of that discharge, put some potassium hydroxide in it, and gives off these amines that has a funny smell, and it's called the Whiff Test. So any 3 of the 4 Amsel criteria could give a diagnosis of bacterial vaginosis. Next one. And that's a clue cell. You see the vaginal epithelial cell, and you see all those little bacilli on the surface there, giving it this granular appearance. Okay, clue cell. Go ahead. And this is the Whiff Test, as I was telling you about. You add a potassium hydroxide to the discharge and gives off these amines, which gives a fishy odor. All right. And well, I probably wouldn't put it so close to my nose, you know, but you smell it. Go ahead. So what is bacterial vaginosis? So a normal vagina, the dominant species is lactobacilli. With bacterial vaginosis, there's a change in the bacterial flora where you go from lactobacilli to anaerobes, all right? And because the anaerobes are there, the vaginal pH is elevated above 4.5. So some of the anaerobes that you tend to see is Gardnerella, you all may have heard of that one, Prevotella, Mycoplasma, Hominis, Mobiluncus, Peptostreptococci. Those are some of the anaerobes. And because bacterial vaginosis is a change in the bacterial flora, all right? You go from the lactobacilli to anaerobes, is not sexually transmitted. So bacterial vaginosis is not sexually transmitted. The nuns who work in the church, they have bacterial vaginosis and they're not supposed to be having sex. All right, next one. So you don't need to bring in a sexual partner for bacterial vaginosis. In terms of treatment, metronidazole is the drug of choice. You have 2 regimens. You can give metronidazole 2 grams stat, or you can probably give it 400 milligrams twice a day for 5 days. With this regimen, the 400 milligrams twice a day for 5 days, there's less relapses. Remember, if you're taking metronidazole, you shouldn't drink alcohol with it because there's this horrible disulfiram reaction people get. So there's only few drugs you don't really drink alcohol with. Also, you can use intravaginal metronidazole gel, or you can use clindamycin gel to treat bacterial vaginosis. In pregnant women, again, instead of giving them the 2 grams stat, the better regimen for pregnant women is 400 milligrams twice a day for 5 days. And with this regimen, you tend to get 70 to 80% cure rates at 4 weeks. And as I mentioned before, it's not a sexually transmitted infection. Next one. Trichomonas vaginalis now. This is caused by the organism Trichomonas vaginalis, all right? It causes trichomoniasis. And 10 to 50% of the women have no symptoms, they're asymptomatic. However, if they do have symptoms, it tends to be itch, they may get burning while passing urine, or they may even get lower abdominal discomfort. The discharge in 70% of the women is described as frothy. So they'll have this frothy yellow discharge. They may get a vaginitis or vulvitis, so meaning that they get an inflammation there, so they may have the itching and the irritation. And they may have a strawberry cervix and speculum examination. I'll show you that. And in this case, the vaginal pH is also increased greater than 4.5. There's a litmus paper you can use for this. Next one. So that's you see the punctate hemorrhages on the cervix. That's the strawberry cervix that they talk about. Next one. And that's the frothy discharge, you see, but I mean, it's not diagnostic, but you see the frothy discharge. That gives you a clue of trichomonas. So what you can do is take some of that discharge, put it on a slide and look under the microscopes, and you can actually see the organisms swimming around. Next one. All right. So posterior fornix, wet mount as they call it. You can also do a PCR also. And sometimes actually, when you get back the pap smear reports, you may also see that trichomonas being reported on the pap smear report, all right? But I mean, the best thing is you can either do the PCR, sometimes you actually do culture for it also, and the wet mount, which is what we do. Next one. All right, and the wet mount will show you these little organisms. Take the next one again. You see swimming around the flagellated protozoan trichomonas swimming around. Next one. All right, so there's what you see. You see the organisms. It's quite spectacular, actually. See the organisms swimming around on the slide. All right, next one. In terms of treatment, again, the same thing. Metronidazole is the drug of choice. For trichomoniasis, you could give the 2-gram stat regimen. In pregnancy, it's better to give the 400 milligrams twice a day for 1 week, all right? Trichomonas is sexually transmitted, so you need to treat the patient's current sexual partner and advise the patient that no sexual intercourse till both parties have completed treatment. And in terms of look back, in terms of how far you go back to do partner notifications, just the current partner. Next one. Candida now, there's the final one I'll talk about. There are a number of organisms that cause Candida, Candida albicans, Candida tropicalis, Candida glabrata, but the common one is Candida albicans. Risk factors for Candida, most women would have gotten a Candida infection during their life. So risk factors include altered immune status, from whatever reason, cancer, chemotherapy, if you're on steroids, you know, increased glucose levels, so patients who are diabetic get Candida, and anything that causes a decrease in the lactobacilli concentrations in the vagina, all right? Antibiotics is a common cause, you know. Patients usually present with itching and burning, or vulva burning. They may present with painful intercourse, and dysuria, pain when they pass urine, okay? Clinically, you may see erythema, redness of the vulva, you may see edema, swelling, and you may see some satellite lesions of Candida. You tend to get a whitish discharge, which varies from, it could be a thin white discharge, sometimes it could actually curd, like in consistency, like cottage cheese. And for Candida, the vaginal pH is usually normal. Next one. So you can see this vulva here, which is swollen, is red, edematous, and you can see the cottage cheese-like vaginal discharge. All right, next one. So the Candida is the most common cause of itchy discharge, is not sexually transmitted, although sometimes Candida recurs in some women, so we tend to treat their sexual partner. It's generally not. Candida is it's part of the normal flora of your gastrointestinal tract and the genitourinary tract. In terms of treatment for Candida, you can use the clotrimazole pessary. That's something to insert. You can use either the 500 milligrams, or you can use one a night for 3 nights. So that's a Candid V3, they call it, okay? Clotrimazole pessaries. Or you can use clotrimazole ointment, that's the antifungal ointment, 3 times a day, or easy. What we tend to use, you give them fluconazole, a tablet, 1 tablet, all right? Fluconazole, 150 milligrams, or you can use itraconazole, 200 milligrams twice a day for 1 day. I tend to use the fluconazole stat plus the canesten or the clotrimazole pessary. Okay, next one. Looking at the sexual history again, you need to ask them about the nature of the discharge, the odor, does it itch, the color, any accompanying pain, any accompanying painful intercourse. You ask them about urinary symptoms, bleeding when they pass urine, any bleeding between the periods, bleeding after periods. Ask about the menstrual history. Ask them about the sexual history, if they use condoms or not, and of course the date of the last pap smear. Method of contraception and condom use. Gynecological history should also be taken. Next one. Again, examination is necessary to exclude other causes if empirical treatment has failed. So usually women will get a discharge and usually go to the pharmacy and buy something, to treat their yeast infection. If the yeast infection is smelly, it probably not is Candida. The smelly discharges tend to be Trichomonas or Bacterial Vaginosis, okay? The examination, look at the external genitalia again, look for fissures, vulvitis, sores, lymphadenopathy, do the speculum again. All right, look at the discharge. Is the discharge in the vagina alone? Is it coming from the cervix, Make sure there are not any plaques or foreign bodies, And of course, do the bimanual examination if indicated. Next one. The investigation, do the vaginal pH. There's a litmus that you can use. If the pH is greater than 4.5, then you think Trichomonas or Bacterial Vaginosis, okay? Candida is a normal pH. You do the endocervical swab for gonorrhea and chlamydia. It can also be urine, but for women, the endocervical swab or the high vaginal swab is better for chlamydia and gonorrhea, all right? You could also do endocervical swab for microscopy, where you actually put it on a slide, and you could also culture it for gonorrhea. Urine dipstick, if you suspect the woman may have diabetes or, if there may be protein in the urine. And of course, when you see all these women, you just screen them for syphilis and HIV, so you do screening for syphilis and HIV. Next one. In terms of Candida, in pregnancy, fluconazole is contraindicated. They don't really like to use in pregnancy, so they tend to use topical therapy in pregnancy, especially the first trimester of pregnancy. So you'll tend to use the clotrimazole pessaries or Candid V3, 1 a night for 3 nights or 1 a night for 7 nights. Now, some women get recurrent Candida, and this is usually more than 4 episodes a year. It occurs in about 5% of women. We don't know the reason why. In that case, I tend to treat the male partner, all right? You should also consider reviewing contraception, as high estrogen pills can exacerbate Candida, all right? Consider a Depo-Provera or progesterone type contraceptive. And usually for this recurrent Candida, some regimens, people use fluconazole 150 milligrams daily for 3 days, all right? And then they would maintain with 150 milligrams weekly for 6 weeks, plus or minus the topical therapy you can use, all right? But recurrent Candida is a problem in some women. I tend to treat the male partner in that case, all right? So in summary, we gave you the differential diagnosis of vaginal discharge. The common causes, as I mentioned, are Trichomonas, Bacterial Vaginosis, and Candida. There are also some physiological causes. Some patients may have allergic contact dermatitis from some of those fragrances that they tend to use down there, all right? Cervical infections, they uncommonly present as a vaginal discharge. In older women, consider the atrophic vaginitis. In the history, you need to establish the nature of the discharge, so the color, the smell, if there's any accompanying pain or any painful intercourse, and also ask about urinary symptoms. If there's bleeding in between the periods or after the periods, if there's the menstrual history is altered, of course, take a sexual history and ask them the date of their last pap smear. All right. Tests to be considered, when you're approaching a woman with a vaginal discharge, the vaginal pH, remember the pH is greater than 4.5, you think vaginal bacterial vaginosis or trichomonas. Of course, you do vaginal swabs for Candida, bacterial vaginosis, and trichomonas. You can actually do that right on spot. So if you have a laboratory technician, you do a wet prep, they can look in the microscope and tell you straight if they see clue cells, bacterial vaginosis, trichomonas, they can actually see the organisms. You can do the chlamydia and gonorrhea, nucleic acid amplification, high vaginal swab, or you can do an endocervical swab, all right? If you're considering gonorrhea and you have a lab that can do gonorrhea culture, you can do culture for gonorrhea. Endocervical swab is not as sensitive as a penile swab for gonorrhea. And of course, you may need to do a urine dipstick if symptoms suggest a need. For example, if you think woman may have diabetes or high protein in the urine, all right? So anyone presented with a vaginal discharge or pelvic pain, you need to rule out the STI, and chlamydia is the most common STI in women less than 25 years of age. So if you're worried, you can give empiric treatment, all right? You do a high vaginal swab for bacterial vaginosis and trichomonas. You do the endocervical swab for gonorrhea and chlamydia, or you can do also urine, but for women, the endocervical swab or high vaginal swab is actually better. And if a woman presents with a vaginal discharge and pelvic pain, you need to do a pregnancy test to make sure that the woman doesn't have an ectopic pregnancy, meaning a pregnancy in the tube. You need to do a vaginal examination, and you need to rule out pelvic inflammatory disease, because this is a serious condition that could actually cause blockage of the tubes and may have severe sequelae. Okay, so thanks a lot. That's my presentation on vaginal discharge.